Good afternoon, everyone. This is Christina Tachiko with the OCAT project. We're extremely excited to have Denise Marzullo from Mental Health America of Northeast Florida in attendance today to present and train on the topic of appraising mental and behavioral health barriers within the CalWORKS population. Denise is a licensed mental health counselor with over 18 years of experience working in nonprofit mental health organizations in Jacksonville, Florida. Denise was named the Executive Director of Mental Health America of Northeast Florida in February of 2010. Previously, she served as the Clinical Director for a community-based mental health provider overseeing the case management staff, therapists, and psychiatrists. I think it comes to no surprise to people on the call that most CalWORKS participants, like all TANF participants, have at least one barrier to work and that many have multiple barriers, among which could include a mental or behavioral health issue. Some national evaluations found that close to 25% of TANF participants have some type of mental or emotional health barrier. While the relationship between employment and these kind of barriers is complex, there is strong evidence the likelihood of employment declines as the number and complexity of barriers increase. Again, no surprise to folks on the call. There's also a strong connection between work and barriers, which makes importance for a comprehensive upfront appraisal. Appraisals of mental health barriers can be challenging, though, primarily because of the stigma that comes with talking about these types of issues. So today, Denise is going to walk us through some new ways to think about mental health appraisals and the stigma that often leads to this fear of disclosing personal sensitive information. There will be a number of chances for everyone to provide feedback on their experience assessing mental and behavioral health barriers through OCAT. So please don't be shy with sharing your knowledge. We will also set time aside at the end of the webinar to answer your questions, so please feel free to type your questions in throughout the webinar. All of the information from today's webinar, including the slides, will be posted on the Learning Center. At the end of the webinar, we will also have a brief evaluation for you to complete to provide us some feedback. With that, I will turn it over to Denise. Denise?
Good afternoon. Thank you for having me. It is my pleasure to speak with you all about using the OCAT and addressing and identifying some of the barriers in regards to mental health and behavioral health. First, I want to say when we talk about behavioral health, we're talking about mental health and substance abuse. Oftentimes, it's hard to determine which causes the other, and oftentimes people have both. They have a mental health and a substance abuse diagnosis. So we're going to kind of talk about the two relatively interchangeable, even though they can be a little bit different. So moving through the presentation, as was noted, make sure that you type in any questions that you might have. We will definitely leave time at the end to address those questions, and we will also have a couple of polls throughout the webinar. So in beginning, what best describes your position within your organization? Are you a case manager? Are you a supervisor, administrative support, or other? I'll give you a few seconds to kind of answer that. It helps to kind of know who the audience is and what your positions are. Do we have the results of that?
Are you able to see it, Denise?
Oh wait, let me see. There we are. I'm sorry. Thank you. Yes, 74% said a case manager. Okay. Followed by 16 is other, supervisor, administrative support. Great. So some of this information is not going to be necessarily new to you. Some of it will be just kind of a reminder of information you already know. Sometimes I like to challenge people's thoughts. Think a little bit differently about mental health and substance abuse, and kind of identify how it might impact your work, your thoughts about mental illness. So as a result of the webinar, hopefully You'll be able to identify some of your own thoughts about mental illness and how it might impact your daily work. Understand the importance of building rapport, why it's important to develop a relationship with people as you're working with them, and hopefully you'll feel a little bit more confident in asking people personal questions about their feelings and emotions. Mental health is a difficult topic to sometimes talk about. People are often reluctant to share personal information, especially with people who they don't know. So building that rapport is really important, and understanding where the person's coming from and building that level of trust as quickly as possible is really critical in getting open and honest information from people that you're working with. So our next poll, do you have a family member or a friend who lives with a mental illness? You can just check yes or no. Give a few seconds. All right, a majority said yes. And it's almost exactly what the percentage is. So we know that roughly 1 in 5 or 1 in 4 people will live with a mental illness at some point in their life. So that's about 20 to 25%. So most of us do know somebody who lives with a mental illness, whether it's family member, friend, coworker. And so what I challenge people to start thinking about now is, what are your own thoughts on mental illness? And obviously in this webinar you wouldn't be answering back, and even when I do this training live, I ask people not to answer the questions that I'm asking. I ask them to just kind of think about it. What are your genuine thoughts about mental illness? So for example, how would you feel if your son was marrying someone who suffered from extreme depression? How would you feel about that? If you know that his wife could have suicidal thoughts and ideation, the effect that might have on the kids if they're severely depressed and oftentimes can't get out of bed and can't function, what would your thoughts be on that? Would you be supportive of your son marrying her? Would you be concerned? Would you be happy because you know you could maybe help them? What are your thoughts? Another thing to think about is, what if your daughter's kindergarten teacher you found out was diagnosed with bipolar disorder? Would that affect your thoughts about that teacher being, your child being in that classroom? Do you think that would have any kind of impact on her education at all? Or if there was a family who had an adult son who lives with schizophrenia moved in next door, would you be concerned? Would you be concerned at all about any kind of safety issues? Would you have any negative thoughts about that, or even positive thoughts on that? What are your thoughts about mental illness? And the reason why that's important is because it's not a bad thing to have different thoughts. We all have our own perceptions about mental illness, and we see things, and we'll talk more about our viewpoint and how our perception about mental illness is developed in a few moments. But it's important that we don't just set it aside and say, oh, I think everybody's equal and we're all wonderful people, but you really evaluate what your genuine thoughts are towards people who live with a mental illness. And so William McKnight had this quote, and I think it's really relative to people who live with a mental illness, and that is, friends, they don't call me sad, they don't call me bad, they don't call me mad, they don't call me. And the reason why I included that is because oftentimes people who live with a mental illness feel very isolated. They feel like their friends don't understand them, they don't understand what they're going through, and so they don't know how to ask questions, especially when they're going through some difficult times. So they just kind of feel very isolated. Their friends don't call them. They don't say anything negative to them. They just don't say anything. And oftentimes that leads to a self-stigma where people then don't like to talk about their mental health issues and their feelings and emotions, and they don't reach out to friends, and it's very isolating for them. And so we're going to use the word stigma a lot this afternoon, and so I want to talk a little bit about what that means. Stigma it goes in kind of 3 levels. So first, there's a problem with knowledge, and we equate that to ignorance. And ignorance is thought of as a negative term, but it doesn't always have to be. Sometimes you just aren't knowledgeable about something. You've never been educated on it. That's kind of my role, and a lot of mental health advocates' role is to clarify some of the myths about mental illness and to help people have a better understanding of what it means to have a mental illness. What are the different types of mental illnesses? What's the severity? How is it caused? What are the treatment options? And so oftentimes people just don't have knowledge about mental illness, and it's not necessarily a bad thing. It's an ignorance, and so it's important to be educated, and why we do webinars such as this one. But then you go to a problem of attitudes, which we equate to prejudice. So if you have certain attitudes about a particular group, so if you label people who live with a mental illness as being crazy, or you have an attitude that maybe they're dangerous, or maybe they are different or weird, then you would be putting people in a category and labeling them, and that would be considered a prejudice. It's an attitude that you have about somebody, and that's more intentional. That's not just not having knowledge. You now, whether you have the accurate knowledge or not, you have a prejudice against a group of people. And then we go to the next level, which is discrimination, and that's a problem of behavior. That's when people make behavioral choices based off of what they perceive people in a particular group to be. So, for example, people might label people who live with a mental illness as being crazy, and so they're rude to them, or they don't communicate with them, or they behave negatively towards them. That would be discrimination. And so when we talk about stigma, we're talking about stigma is the negative view of a group or a person based on a certain perception about them. Often people living with a mental illness experience stigma as a result of how they were perceived at a period of time when they were not well. So what we see in the media often is people, they'll say a person has a mental illness, and then they'll show something negative that they've done. And so that's the way people perceive mental illness. If you have someone in your family who you know has a mental illness, you'll remember them based on something maybe negative that they've done or experienced. It's rarely because of maliciousness. It's more often, again, a lack of understanding. And oftentimes stigma is perpetuated and fueled by insensitivity or ignorance. And again, like I mentioned before, worse than the stigma received from others is often the self-stigmatizing, because they know that there's people out there who don't understand them, who are ignorant, who do have prejudices, and will discriminate against them. So they don't seek treatment, and they often stay isolated, which makes their mental health a lot worse. So when we talk about prevalence and some of the negative attitudes towards people with a mental illness, this has persisted over a long period of time. So when I asked those questions, they did a polling a couple of years ago where respondents were asked questions, and over 70% of the population would not want a person with depression to marry into their family. And it may not have been because they don't like people with depression. It might be more the concerns about the effects on the kids, or the concerns about their child having to deal with somebody who is suicidal. That's very, very tough and stressful to deal with. 70% rated people with schizophrenia as dangerous. We're going to talk a little bit more about some myths about mental illness, and one of the myths is that they're dangerous to others, and the truth is that oftentimes people with a severe mental illness are more dangerous to themselves or to their really close loved ones than they are to strangers, and we'll talk a little bit more about that. 73% of characters with a mental illness in TV dramas were portrayed as violent, and I think that's oftentimes where people get their knowledge about mental illness and why there is this stigma and this negative perception about people is because if you see 73% of characters with a mental illness were portrayed as violent, and that perpetuates this stigma. Only 19% of people said that they would be comfortable around someone with a mental illness, which makes me giggle a little bit because you're around people who live with a mental illness all the time. If we know that 20 to 25% of our population will have a mental illness at any given point in time, every time you go into a movie theater or a restaurant, there are people who are living with a mental illness, and you're quite comfortable even though you don't know that they're there. So again, it's the ignorance and the lack of knowledge, I think, that results in that. People with mental illness are viewed more negatively than our ex-convicts. I think that's really sad. People who live with a mental illness, we'll talk a little bit more about what mental illness is. It's a brain disease. It's a disease of the brain. It's an illness. Just like cancer, just like diabetes, they shouldn't be viewed as negatively for having an illness. Oftentimes, untreated, it leads to certain symptoms and certain behaviors, but they shouldn't be viewed more negatively than should ex-convicts. And unfortunately, TV is one of the main sources of information on stigma, which we've talked a little bit about. So some of the top 10 myths about mental illness. Myth number 1, psychiatric disorders are not true medical illnesses like heart disease and diabetes. People who have mental illness are just crazy. And we just talked about that. They are legitimate medical illnesses. They can be genetic and biological causes, and some can be environmental causes. We'll talk a little bit more about that. But they can be treated effectively. All mental illnesses can be treated, not necessarily cured, and that's really important to understand the difference. It's not that if someone has a mental illness, you give them some medication, maybe some therapy, and in a certain period of time it'll just go away. Sometimes mental illnesses can be acute like that, and a mild depression can last 6 to 9 months, and then you're better and mentally healthy the rest of your life. However, oftentimes some mental illnesses are more chronic. ADHD in children is oftentimes a more chronic mental illness. Depression can be chronic or acute depending on the depression. Bipolar disorder, schizophrenia are your more chronic mental illnesses. With the right course of treatment, whether that's support groups or therapy or medication management, it can be treated, but it doesn't necessarily mean that it's cured. Myth number 2, people with a severe mental illness such as schizophrenia are dangerous and violent. And the fact is that statistics show that the incidence of violence in people who have a brain disorder are not much higher than the general population. Those suffering from a psychosis such as schizophrenia are often frightened, confused, and scared rather than being violent. So we hear on the media stories of people with a mental illness being violent, but you also hear of people being violent in the media who don't have a mental illness. And so there really isn't that correlation as much as people often think that there is and associate it with it. Myth number 3, mental illness is the result of bad parenting. That is so inaccurate and false. Mental illnesses oftentimes do have a physical cause. It's not to say that kids can't develop trauma and other adjustment disorders as the result of bad parenting. Absolutely, that happens. And as workers in this field, you've seen it happen where a parent isn't a great parent, and oftentimes the kids have the effects and live with the effects of that, and that's not necessarily what we're talking about. We're talking about if someone grows up and has bipolar disorder, it's not necessarily because they had a bad parent. Myth number 4, depression results from a personality weakness or character flaw, and people who are depressed could just snap out of it if they tried hard enough. We often hear, just pray about it and you'll get better, or just snap out of it, you're fine, everything's going to be okay. And oftentimes it's a lot more severe than that. Depression can result from changes in your brain chemistry, and people do need medication or therapy in order to recover, but it certainly doesn't have anything to do with being lazy or weak. Myth number 5, schizophrenia means split personality and there's no way to control it. Schizophrenia is often confused with multiple personality disorders. Schizophrenia is a psychotic disorder, and what that means is that a person has hallucinations or delusions. They hear voices, they see things that aren't there. It's a very scary disease to have when your reality is hearing these voices and it's hard to determine what's real and what's the voices. Whereas multiple personality disorder is often based off of, it's now called dissociative identity disorder. That's based off of some very severe trauma that a person has experienced to where they had to create a whole nother personality in order to deal with that trauma, and that personality lives within their brain. And those are two very different diagnoses. The dissociative identity disorder or multiple personality disorder is much less common. It's very, very rare. Whereas schizophrenia is a psychotic disorder, and as a matter of fact, 2.5 million Americans live with schizophrenia every day. Myth number 6, depression is a normal part of the aging process. That is not true at all, and we need to be very careful about people who are elderly living with depression. We know that the suicide rates in our elderly are very, very high, and it's not a normal part of the aging process. It often happens because our elderly often experience a lot of loss as they get older. They might lose their spouse, their family members, and sometimes, unfortunately, their children may not outlive them. And so there is a lot of grief, but it's not, depression is not a normal part of the aging process. Myth number 7, depression and other illnesses such as anxiety disorders do not affect children or adolescents. Any problems they are having are just part of growing up, and that's absolutely not true at all. Children and adolescents can develop severe mental illnesses. 1 in 10 children or adolescents had a mental disorder severe enough to cause impairment. However, only 20% receive treatment. And again, I think that's the lack of knowledge. I think oftentimes our parents don't realize that their child could have an anxiety disorder or depression, and so they don't even think that maybe they need treatment. They think, oh, their child will just grow out of it. They're just different. And so we need to make sure that we're educating parents on some of the signs and symptoms of mental illnesses in children so that they can get them the help that they need. Our pediatricians are getting trained constantly on identifying some of the signs and symptoms so that they can help address it and educate parents if they do need to see a specialist. Myth number 8, if you have a mental illness, you can will it away. Being treated for a psychiatric disorder means an individual has failed or is weak, and that's a myth. Serious mental illnesses are brain diseases. You wouldn't will away heart disease. You wouldn't will away cancer. You would get treatment, and that's the same for a mental illness. You need to get the right treatment. Myth number 9, addiction is a lifestyle choice and shows a lack of willpower. People with a substance abuse problem are morally weak or bad, and that's absolutely not true. Addiction is tough for some people to understand. They say, well, just don't do it. Just don't drink. Just don't use the drugs. And if you just had more willpower, and that's absolutely oftentimes not the case. Addiction is a disease, and it does change your brain chemistry. It has nothing to do with a person being bad or lacking willpower. And finally, electroconvulsive therapy, ECT, formerly known as shock treatment, is painful and barbaric. It used to be, but now there's been a lot of research and a lot of studies done on ECT, and people who live with severe and extremely debilitating depression, it has been very successful with. And so oftentimes there are people who have severe depression where medication and therapy just isn't working, and they found that ECT treatment does help them. They are asleep, they are under anesthesia, so they don't feel anything, yet it has been effective on some people. So the truth about mental illness, like I said, 1 in every 4 Americans suffers from a diagnosable mental illness in every given year. However, only 1/4 of them seek treatment, and oftentimes that's due to that self-stigma that we've talked a lot about. People are afraid to get treatment. They don't know how to get treatment. And oftentimes, depending on where you live and the type of insurance you have, treatment is just not accessible. You can't afford it. You can't get it easily in certain communities. I live in the state of Florida where we are 50th in mental health funding for mental illness. So there's significant access and capacity issues here in the state of Florida in getting treatment for mental illness. For the 10 leading causes of disability worldwide are mental illnesses, and what's really important is that mental illness doesn't discriminate. It affects people of every race, gender, and economic background. It's not just, quote unquote, those people over there who have a mental illness. It affects everybody. And that's really important for people to understand. It can affect anyone in their family at any given time. And the direct cost of mental health services in the United States is approximately $69 billion. And yet it gets very little attention and very little education. So what is it that we're talking about? Mental illness is a term that refers to disorders that are characterized by disturbances in thinking, mood, or behavior, or combination. And so the biggest question that I get asked is mental illness genetic or is it environmental? And the truth is that it's one or the other or both. So there's not a clear answer. You have some mental illnesses that are genetic. For example, bipolar disorder is genetic, oftentimes in cause. And so if you are, and this is hard to describe in a webinar, but if you are a girl and your mother has bipolar disorder, you have about a 50% chance of having bipolar disorder, whereas your brother, so he's a boy, and your mom has bipolar disorder, he has about a 25% chance. And these are rough estimations. So it goes by gender, and it goes hereditary. However, we know that diagnoses such as post-traumatic stress disorder is certainly not genetic. You could be going through life, have no genetics to predispose you to PTSD. However, you become the victim of a severe trauma like a rape or our military going off to war, and when they come back, they have post-traumatic stress disorder. So it certainly wasn't anything chemical. It was simply an environmental. Same with depression. We know that depression can be both. It can be genetic. It can be inherited. If your family has a strong family history of depression, then there is a stronger likelihood that you might have depression. However, we know that plenty of people do not have any genetic predisposition to depression, yet they suffer tremendous loss, death of loved ones, or a divorce or financial causes, and they become severely depressed. So that would be more environmental. It's really important to understand that mental illness is on a continuum. You can be mentally healthy and very mentally healthy for most of your life and then have something happen to where you're more along the lines of a mental illness. And so it is along the lines of a continuum. It's not either you have it or you don't. At some point in your life, you could have some struggles with your mental health, and then you could kind of go back and forth and then get back healthy again. So some of the signs and symptoms of mental illness, a person with a mental illness may complain of certain symptoms. Those are the subjective feelings, whereas the signs are the observable behaviors. So for example, a person may say, I feel low, sad, depressed. Those are the symptoms. However, they may look, their affect is really sad. They may have trouble moving. They move very slowly. Those are more signs of depression. The more symptoms and signs a person has, the more likelihood that they have a mental illness. The way we diagnose mental illnesses is based off of the Diagnostic Statistical Manual. It's called the DSM for short. And so unfortunately with mental illnesses, and the thing that makes them sometimes very difficult to understand is that there is no blood test or no CAT scan or MRI to say, yes, you have a mental illness, or no, you don't. It's based off of signs and symptoms, and often not self-reported. And so based off of those signs and symptoms, a treatment provider, a psychiatrist, or a therapist will determine what the diagnosis may be. And so what you see there is a list of different types of mental illnesses. You have adjustment disorders, anxiety disorders, dissociative disorders, which was multiple personality, the eating disorders such as bulimia and anorexia, impulse control disorders, mood disorders, that's your depression, bipolar disorder, personality disorders, psychotic, sexual disorders, sleep disorders, somatoform, and substance abuse. Those are the different types of mental illnesses that are in the DSM. So as we talk about what depression looks like, I mentioned that it can happen, it's regardless of age, race, socioeconomic. These are all people who have struggled with depression at some point in their life, yet they've been successful, whether it's Abraham Lincoln or Princess Diana or an athlete or a comedian or an actor. You can have depression and still be successful. Same with bipolar disorder. Many people have come out and talked about their life with bipolar disorder. We've seen Catherine Zeta-Jones in the news struggle with bipolar disorder. Same with Owen Wilson, and for our younger folks, Demi Lovato. She's an amazing advocate for mental health. So going back to the stigma, when we talk about some of the harmful effects of stigma, it leads to people being reluctant to seek treatment or help. It leads to a lack of understanding, fewer opportunities for work. Oftentimes people are bullied, or even people have been violent towards people with a mental illness or harassed. Sometimes health insurance doesn't adequately cover your treatment as well. And people who live with a mental illness, depending on how severe, sometimes have a belief that they'll never be able to succeed or that they can't improve their situation. So, which is what leads to discrimination. So people with a mental illness oftentimes have discrimination at home. If their family doesn't understand them, they can be viewed as being lazy and weak. You just need to get off the couch and get a job. People can have negative reactions to family members where they don't invite them to Thanksgiving dinner because they don't know how they're going to act. There's very high rates of homelessness. We know that people, especially people with psychotic disorders and oftentimes bipolar disorder, they have a lot of trouble interacting with their family, and they can kind of burn their family out to where they can't live with them or don't want to live with them. And oftentimes people who live with a mental illness would prefer to be homeless than live with family members. As I asked the question at the beginning about would you want someone with a severe mental illness living in your neighborhood, oftentimes neighborhood have significant reactions to people with a mental illness living in their community. So we know that there have been community efforts to block apartment complexes from being built to house people who live with a mental illness. So there's a lot of discrimination. There's also discrimination in friendships and intimate relationships and childcare. It can be tough to live with someone with a mental illness, as we talked about, some of the suicidal ideation and some of the extreme behaviors of untreated mental illness can lead to divorce and friends kind of disappearing because they just don't understand or don't want to deal with it. There's impaired long-term sexual relationships that often are a consequence of mental illness. So now that we have a better understanding of mental health and mental illnesses, we can talk a little bit about the OCAT tool. And these are some of the questions that you are asking people when you're just meeting them. And sometimes you may be uncomfortable asking personal questions of people, which is definitely understandable. And so recognizing your own feelings about asking the questions is really important. And then understanding that other people who you're interacting with might have never disclosed any of this information to somebody else before, and now you're asking it of them, and you've only known them for a little while. So kind of let's talk through what some of these questions mean so that you can more adequately describe them to people. So instead of just saying, are you depressed, are you fearful, are you worried, you want to kind of take your time and ask questions like, so in the last 30 days, have you felt depressed, kind of sad, maybe feeling worthless, kind of like you don't want to get out of bed in the morning? So instead of just saying, are you depressed, you can kind of describe what that might look like. It might look like feeling sad, feeling worthless, feeling hopeless. Going to the next one, are you fearful? So do you ever feel scared but you don't really know why? Has that ever happened to you where you just kind of are sitting around and you feel anxious or worried or fearful but you don't really know why? Are you worried about just kind of everything in general, not just something specific, but do you find yourself being kind of worried constantly and all the time? Are you nervous or anxious but don't really know the cause? We can be nervous or anxious going into a job interview, but if you're sitting in your living room where you should be comfortable, are you feeling kind of nervous and anxious and you don't really know why? Tired and exhausted even though you've been sleeping well, so you've been getting a lot of sleep, yet you still feel tired and exhausted. Does that ever happen to you? Are you ever feeling not motivated, like you're kind of just fatigued and just kind of don't feel like doing anything? Does that ever happen to you? So kind of clarifying it versus just saying a list. If someone said to me, are you depressed, fearful, worried, you probably would just say no, no, no. But if you ask questions such as like, have you, in the past 30 days, do you feel like you're just kind of tired all the time? And if you're more careful and more if you explain it more as you're asking the question, it'll help to solicit a more honest response. Have you ever experienced or witnessed a frightening or violent event? You might need to clarify that or give examples. For example, have you ever experienced or witnessed domestic violence or severe abuse or something violent such as war or a shooting? So you might need to give examples. Have you ever wanted to or thought of hurting yourself? So we know that most people think about it at some point in time, and so if you can kind of ask the question so it's in a non-judgmental way. Have you ever wanted to or just kind of thought of harming yourself? Have you ever wanted to or thought of harming someone else? Have you ever had trouble sleeping even if you are tired? So you're exhausted but you just can't fall asleep. So again, it's clarifying what you mean as you're asking those questions. And are you currently getting help for any of these conditions? Are you going to a support group? Are you getting individual therapy? Are you getting medication management? You want to, again, clarify the questions. When it comes to the substance use and alcohol and drugs, people are going to be very reluctant to answer some of these questions. And so, again, you want to be careful about asking them and letting them know, you're just asking them to fill out this tool and not to be insensitive. Do you regularly consume alcohol, including beer, wine coolers, or cocktails multiple times per week? How often? How many drinks? Have you ever cut down or quit drinking or using drugs? And so being sensitive to the fact that people just are going to have trouble kind of sharing this information. They don't want you to judge them, and they've probably been judged before. So we'll go to our next poll. How comfortable do you feel, now that we've gone over some of those questions, how comfortable do you feel asking the emotional, mental health, and substance abuse questions? Give you a few seconds to respond. Great. So a majority feel either somewhat or very comfortable. That's really good. I'm really happy to hear that. I'm sure it's because of the webinar and all the information you're getting. It's probably because you're sensitive to this and you're helping professionals, and so you feel more comfortable, and that's really good. And if you're a little uncomfortable, if you're part of that 15% that's either very uncomfortable or a little uncomfortable, you might want to kind of think to yourself as to why. Is it because you need more knowledge about it? Is it a sensitive subject to you? Maybe you struggle with mental illness yourself or a family member, and so it's a little tougher for you to ask those questions. And so it might be something where you may need a little bit more coaching or training or education because you want to try to be as comfortable as possible in working with people and asking these types of questions. So how to build rapport. It's no secret that we must get clients to trust us and feel comfortable in this application process. If you don't, then they won't share important information. If they don't trust in what you say, they won't participate in the process. So how do we build rapport? You want to use your active listening skills and understand the client and their story. Taking just a few extra minutes to let someone share their story is really powerful in building rapport. I definitely can appreciate the fact that you probably have very limited time to get a lot of work done. I am very sensitive to that, but taking just a few minutes to really listen to them and help them know that you are listening and you do want to understand where they're coming from and what their life experience has been can go a long way in building rapport. You want to watch your speed, and what I mean by that is your speed of intimacy. So depending on the person's culture or their background or their personality, it may take them a little bit longer to build trust. So you want to pay attention to what they're sharing, to their body language, and you want to kind of take your time. If you see that someone feels a little bit more uncomfortable, kind of give them a chance to kind of get a little bit more comfortable. Ask them some more benign questions before you jump into the have you ever been depressed kind of questions. You want to help them, if they're in a strange situation, they're in your office and they've never been in there before, so kind of let them gather their bearings and figure out kind of where they are and who you are before you just kind of jump in. So take your time. Treat the client with respect. I know that's obvious, but you really, really do want to always treat your clients with respect. Returning calls promptly as best as you can. Start stuff on time. Have everything ready. Respect their time as you would like them to do your time. Imagine how you would like to be treated if you were a client, and kind of think about that. If your mom was walking into the office, how would you want her to be treated? And that's really important to think about. Small successes first before delving into the biggest problem. Try giving helpful information, positive feedback, encouragement. As they're starting to answer some questions, you can say things like, thank you for being so open and honest with me. I know that these are kind of some difficult questions, and I appreciate your candor and your willingness to answer the questions. Match styles. Watch your client become aware of their communication style, and then try to match yours with the rhythm. But make sure you don't do it too much. So if you have a hyper client, you want to try to stay a little bit more calm because then they might start to mirror your behavior and kind of calm down. If you have an anxious person and then you appear nervous and anxious, it's just going to escalate it. Whereas if you can kind of calm down, you can mirror that behavior for them. Be competent. It should be obvious, but the best way to destroy your relationship is to be incompetent. So the client's not going to trust you if you appear that you don't know what you're doing. So kind of show them, I've been doing this for a long time, and I understand that this is a weird environment, weird questions to answer, but just know I know what I'm doing, and we're going to get you through this process. And so fake it if you have to. Next, self-disclosure. Disclosing personal information is another way that you can build rapport, but you don't want to spend too much time. So you don't want someone to walk in and say, well, yeah, I've had depression in my family, and my mom's been depressed, and this and this and this, and talk 10 minutes about yourself. The person doesn't want to hear that. But if you do see someone a little bit uncomfortable, you can say something. I have a sister who struggles with depression, and she would have a hard time answering these questions too. So I totally understand, and we'll kind of take our time as we're going through this, and just let me know if you want to take a break or if you ever feel uncomfortable. So you want to make sure that you don't make it about yourself, but it is okay to kind of normalize things for people and to help them feel a little bit more comfortable. And sometimes disclosing the information is a good way to do that. And so these are just some sayings that I have and that I like to share with others. The one that I like the most is the one in the middle with the two guys shaking hands that says, can we swap glasses? It helps me to see things from the customer's point of view. So as you're asking these difficult questions of people and getting to some sensitive information, you want to kind of be able to see things from their perspective. And you would never say it's just cancer, get over it. So we don't want to say that about mental illness. And now we have time for questions. Oh, I'm going to leave my information on. If you have any other questions or anything that you think that I can help with, that is our website. We have a lot of information on that website, including screening tools. And then that's my email and phone number if I can ever help in the future. So now we will get to some questions.
Thanks, Denise. So folks, yeah, go ahead and enter your questions into the question box and we can feed them to Denise. Got one question here that came in, and I'll try to paraphrase a little bit. So basically implying that someone has mental health barriers and needs additional support can be a kind of a tough pill for some folks to swallow. Are there any tips for helping folks kind of take that, that quote-unquote first step in following through on a mental health referral?
Absolutely. So some people are going to be way too intimidated to go, for example, and see a psychiatrist as their first view into this world. So suggesting that someone goes to a support group might be a lesser, a less scary environment to go to. I also tell people all the time to have a loved one go with them to a doctor's appointment or to a psychiatrist appointment. It can give them someone to talk to, and it's a lot less scary if you have someone with you. As you're telling someone, you would be in different situations where someone is learning that they might have a mental illness. It's important to give information. So it's important for people to understand they're not the only one that's living with this. Lots of people do. There's lots of information. You want to help kind of, I've approached people before in my own personal life where I've said, I'm really concerned about you, and I've noticed some things, and I looked it up, and here's some information on depression, and it just kind of sounds a little bit like you. What do you think? Can we talk about it? So you want to be there for them. If it's a loved one, if it's a client, you want to be able to give them information, give them lots of different levels of care and options for them to go to. So a support group, a therapist. Oftentimes, if people have trust with their primary care physicians, and so going to your primary care physician first can be a great, less threatening step to take.
Great. Thanks, Denise. And again, folks, if you have any questions, go ahead, just type into the question box. I've got one more here. And again, I'll try to paraphrase a little bit. So I've been in situations where clients with mental health barriers have become upset when we've kind of alluded to the fact that they might have these issues, to the point where I was a little concerned for my safety. Do you have any suggestions for, I guess we could say, conflict resolution strategies that case managers can use in these situations?
Great question. So every organization that is working in a mental health type environment should have different policies and procedures to follow. And so you want to make sure you follow those. But and really answering her question, you want to make sure that you're aware of a person's body language. So if you see them getting a little bit upset or agitated, aggravated, you want to back off. You don't want to continue to escalate the situation. So if you asking about somebody's, let's say, substance abuse in the past, if that starts to get them agitated, you might want to say something to the effect of, I can see that this might not be the most comfortable line of questioning to ask, and maybe we kind of get back to this some other time. If you are at all uncomfortable with anything I'm asking, just tell me, and we'll stop and move forward to something else. There's no point if someone is being aggravated by questioning or by even the conversation that you're having, even if you're not specifically asking questions, there's no point in continuing it because it's only going to make it worse. So acknowledging it, being honest about it, and saying, you just kind of seem to be a little bit agitated, and that's okay. That's totally understandable. I don't want to do anything to make you feel uncomfortable. We can stop right here, maybe come back a different time. You want to kind of be very sensitive to what people are going through, and you don't know what buttons somebody has that others don't. So being aware of body language, being aware if someone is getting agitated, and if it gets to the point where you do feel like your safety is possibly going to be compromised, you want to make sure that you're safe first. So kind of saying, I'm going to step out for a minute and I will be right back, kind of stepping out of your office, getting somebody else, to help with you is definitely appropriate. And again, following your agency's protocol is critical.
Thanks, Denise. And I know you've kind of referred to this in the beginning of your presentation, but I think for a lot of folks, from what I'm seeing, is one of the biggest issues is this, for clients, is this fear of being quote unquote labeled. Any other thoughts or information or suggestions around kind of, I guess, helping lower that sense of anxiety around, again, like being labeled as someone with a mental health issue?
Great question. So I think being honest with what you're there to do, you're not there to give them a diagnosis. That's not your job. You're not there to tell them you have a mental illness and now we're going to check this on this form. That's not what it's about. And so letting people know from the beginning, listen, I'm not here to judge or label or to give you any kind of diagnosis. I just have this form that I have to fill out, and we're trying to make sure we can get you the services that you need to help you and your family. And so I'm going to ask some questions, and again, I hope that you know, and I hope that you can trust that I'm not at all asking these questions to judge you or to label you. That's certainly not my intent. So kind of saying that from the beginning can help alleviate some anxiety that people might have, and letting people know, there's no consequences to any answers. We're not going to hospitalize you here. If we do see some things that are concerning, we might give you some more information or even give you some resources to get some follow-up help. But just know that my job here is just to kind of help you in identifying what some of your strengths are, what some of the areas that you might need some support with, and certainly not to judge or label you or to diagnose you.
Thanks, Denise. A couple more questions have come in. I think one's very specific to OCAT. I think we can answer that offline. Another question, though, this is a good question I haven't seen before. In OCAT, there are similar words used for the questions, such as scared and fearful. Is there a difference, and how should we describe these?
I don't think there's a difference. You're going to use scared and fearful interchangeably, and so it's okay to, and sometimes it's done intentionally, to ask it a couple of different times. And so I think that they're the same. I would use them interchangeably. I'm pulling up the slide with the tool. So you can even kind of say, I know we asked about fearful, and you answered most of the time when I asked you about fearful, so that'd probably be the same for scared, right? You can even ask it like that, I would imagine. And sometimes it is to just kind of make sure that it's being asked over and over again. It's the same with the tired and exhausted is F, and then having trouble sleeping even if you're tired. Some of those can seem the same too, and so I think even acknowledging it is fine.
Great, thanks, Denise. And I'll give folks just one last opportunity to ask a question. We've got a couple minutes, but I think we may be good. So Denise, thank you so much. It's a fantastic presentation. Thanks for everyone on the line who participated. And again, if folks can just hold on for a sec, we'll do a quick evaluation slide. Just got to advance that. There we go. And again, Denise, thanks so much. Much appreciated.
Thank you.
Have a great week. Bye-bye now.
Bye.